So thank you so much for being here this morning on the last day of the conference early this morning. I hope you've had a chance to get your coffee and wake up. And I know we have people from different time zones, so maybe it's already, you're already moving into the lunchtime hour. So it's wonderful to be with you here today to talk about value-based contracts, alternative payment methodologies, and how they support the mission that we have as community health centers, migrant community health centers. So I'm going to see if I can advance my slides.
Perfect.
Okay, so I want to start out with a little bit of background about who I am and our organization. So I'm Gil Muñoz. I'm the CEO of Virginia Garcia. I've been with the organization now nearly 31 years, and the organization is 46 years old this year. We take the name of Virginia Garcia from this young girl who you see here. Virginia Garcia came up from Mission, Texas with her family and the migrant stream, worked the fields alongside of her parents and her brothers and sisters. But sadly, she cut her foot and through an infection that became septic. She died at the age of 6 in Washington County, which is the just west of Portland area. At that time, there was really no dedicated services, health services for the farm worker population. So her death really inspired the community, became a catalyst to get the first clinic started there 46 years ago. This picture you see on the screen is that original clinic, which was in a 3-car garage. So Virginia Garcia has had this mission to provide high quality, comprehensive, culturally appropriate healthcare for the communities of Washington, Yamhill counties, with a special emphasis of migrant seasonal farm workers and others with barriers to receiving care. It was a major organizing effort for the community leaders to start Virginia Garcia, and it has now, as you'll see, we have moved on to serving over 52,000 patients across 2 counties. And we have 21 sites. Our area of where we're situated has both urban and rural areas. So we have 5 main primary care sites, but we also have a mobile clinic that goes out to the migrant camps, to nurseries, to vineyards, to other areas in the community. And over the years, our populations have really become more and more diverse. So our patients speak over 60 different languages, and we offer the full comprehensive care of primary care, dental, behavioral health, pharmacy services, and wellness activities. And we're also seeing more and more refugees and people from Middle East, from Russia, Africa, who are coming into our area. So our mission has stayed the same, and but the populations have really diversified over the years. So I want to start, although this is really about maybe some of the financial aspects of value-based pay and care, but I always start with the model. What is the model of care? Because that's the important thing. The model should always be the one leading the payment. Okay, we're trying to align the payment with a model of care that we think will be best to meet our community's needs. So I love this quote from Doug Eby, who's the vice president of medical director at South Central Foundation. He says, "We're not in the pill and procedure business. Healing is being in relationship over time with caring, knowledgeable people. We're in the service business first." And we have to remember that, even though our technology is increasing and our payment systems can be more sophisticated, but really it's about relationship. It's about relationship between the provider and the patient, but not just the provider, it's the whole team. And we're going to talk about that. So why did we've been on this journey for 15 years now of moving towards value-based pay. And so what was it that was really driving us to change? So before we were in an alternative payment methodology, we were on fee for service, and maybe many of you are there at this point, and encounter based. So everything was, our reimbursement was driven by volume. How many visits could you get through the door? How many, what was the level of procedures that you could do? And so our providers were feeling like they're on a gerbil wheel. They're really kind of getting burnt out by that, and it was not very provider or team centric. It was everything had to go through the provider, or else the claim would not go out, and we would not get the reimbursement. And there was really not an incentive to really engage all the members of the team for that care. And then we were limited in our in the services that we could provide. So we're always looking at, okay, what's billable, what's not billable, and then so important things to the health center, like outreach, like addressing social determinants of health. Well, there's no ICD-9 or CPT code, to bill those kinds of things. So those were always done through grants and, donations and other things. But because the reimbursement system was driven by fee for service and encounters, that's what, it takes precedence in how the model of care was developed. Although that's not, I would say, is how community health centers started. If we think back, when community health centers started, there was a real emphasis on looking beyond just that medical visit, and looking at the community, looking at what are the broader needs, whether the food insecurity or sanitation or housing, those things that also impact the health of the community. But with the traditional fee-for-service system, you're really limited on how we're able to respond to those, except through grants and other things. So the system was really not geared towards this preventative view. So back in 2006, so 15 years ago now, we sent a delegation to Alaska to really view the system they had there at South Central Foundation, and came back, and not just Virginia Garcia, but a delegation of Oregon health centers, and came back very inspired and looking at how can we implement this model of care in our communities. And so then that started a collaborative that really turned into what we know today as PCPCH. So a lot of those elements were things that we observed and then started to integrate back then in 2006. In 2012, we actually launched our alternative payment methodology. And I want to say that this would not have happened without the leadership and the work of our primary care association, and really with the collaboration of the Medicaid agency in Oregon, the Oregon Health Authority. There was an alignment in terms of a vision of care, and Oregon has been very progressive in trying to move forward with alternative payment methodologies and transforming care, particularly in the Medicaid area. So we were very fortunate to have that support and leadership at the state. And you may not have an APM in your state, but I really highly encourage you to work with your state associations and build those relationships with state Medicaid to really look at moving forward with alternative payment methodology for the health centers. Also, around the same time that we implemented our APM, the state did a major transformation through an 1115 waiver with the rollout of coordinated care organizations. This really set the stage for moving us further down the road towards value-based pay. And then in 2019, they launched what's called CCO 2.0, but that in 2020 got completely derailed by the pandemic. So for the last year, we've mainly been dealing with the pandemic and not advancing so much on our goals for CCO 2.0. But we look forward to getting back to that after we have gone through and vaccinated our community. We're about a third of the way there. So when we are thinking about the model of care, it's really centered around the patient. And what is this team that we have centered around the patient? You know, this is maybe familiar to you, and you may have a similar setup. But we really moved to a team-based approach. Pre-APM, we had all the doctors on one side and nurses on the other, and they had their patients, but it wasn't really a panel of patients for a team to really address their needs. Everything was run through the provider. Now it is really it's a team that takes care of the panel, and that includes nurses and medical assistants, but also behaviorists, clinical pharmacists, and with the support also of community health workers. And for our migrant and farm worker population of migrant camp outreach workers who are at this time of the year gearing up for the start of the camp season. We observed 5 pillars that we wanted to implement from the system that we observed in Alaska, and one was this focus on team-based care. The other was proactive panel management. So not just thinking about the patient who is in the waiting room or the exam room, but who are the people who should be coming in, who are not coming in, who need to come in because they're in need of a cancer screen or well child check or diabetes check. So really thinking about the whole population, and then trying to have an open access or advanced access system, so that people can get in that day, or we look at something called third next available to really gauge how easy it is for people to access care. And we try to keep that third next available under 5 days. So that means that they have at least 3 opportunities to come in within 5 days. So that has been very important for our patients to feel like they can access their provider and their team. Behavioral health integration is hugely important. We know that the control of the a patient's health is really within themselves, within the patient themselves. They're with the provider and with the team just a very short amount of time, and they can receive a diagnosis and a treatment plan. But whether they follow that, whether they take their medicines, whether they adopt the healthy behaviors, is all within the control of the patient. So having behavior is really working with our patients, particularly those who are chronically ill, has been very important component of the model. And then owner-driven care. Community health centers are already inherently set up this way, by having our patients on the board of directors, so they provide us that direct feedback, and help us model our services. So this was the model of care we were trying to implement, but we were trying to implement this under a fee-for-service system. And it was frustrating for us because a lot of things that we were trying to do were not getting reimbursed. So it would stretch the organization financially. So we really looked at marching up this pyramid, and again, this was over 15 years that we did this, but we started out with grants from the organizations that were supportive of us, the health plans that understood what we were trying to do, and so they would provide us grants, or United Way or some private foundations. That helped us get started. That was the investment in some of this infrastructure. And then we worked on some policy change to work with state Medicaid agencies so they would begin to adopt codes that recognize the services like behavioral health assessment codes, the role of behaviors in primary care, so we could get reimbursed and we could get our PPS rate, for those services. And then looking at changes in scope for our PPS so that we can start to incorporate these different elements of the model. Finally, we looked at an alternative payment methodology for our wraparound services, and I'll talk a little bit more about that in a moment. But then finally, at the top, you see here is a payment for outcomes, or value-based pay, and that's where we are today. And so it's really been a move upward towards this idea of paying for outcomes, paying for value, not just paying for how many encounters or how many procedures can we do in a day. So it's really a whole change in a mindset. So Oregon has been very fortunate to have an alternative payment methodology to help align our reimbursement with the model of care. And so as health centers, we have our PPS rate, and in Oregon, we have managed care for Medicaid services. So we were paid by the managed care organizations, but then our wraparound payments are paid by the state. So that is that difference between our rate and what we receive from the managed care organization. So with the collaboration of the state Medicaid agency, we turned that wraparound payment into a per member per month, so that we weren't paid on an encounter basis anymore. We were paid on the number of patients that we had engaged. So for that number of members, we would receive a per member per month payment from the state. while we were still receiving the reimbursement from the managed care organization. And sometimes that was on a fee-for-service basis, or what we've been able to do now is even move those into a per member per month also, otherwise known as capitation. So we're receiving capitation payments from both the MCO or the CCO in Oregon, and then also from the state for a wraparound. So these two payments align around the population we're serving. So not the number, not the volume of visits anymore, but the people who we're serving. That's been hugely important. The other thing about the APM is that bonuses related to quality, and those are all outside of that core rate for the monthly per member per month. So if we achieve our targets, for our clinical metrics, that's on top of that base payment. And then we had a commitment, an obligation with the state Medicaid agency to make this a budget neutral proposition, with the state. So when we converted our PPS wraparound to per member per month, we had to make sure that was a budget neutral proposition for the state, and which allowed them to support it. And so the way that it is set up in Oregon, this per member per month alternative payment methodology is for our physical health services. Currently, mental health services are carved out, dental services are carved out of that, and prenatal care deliveries are carved out. So we're still on an encounter basis, fee for service for those services. But everything else that, from a physical health standpoint, is paid under the APM. And then we have just received an agreement and started to implement a change in scope process for the alternative payment methodology. So, as things have changed over the years, there's a need to adjust the PPS rate. And so now we have a methodology on how to make that change also within this APM. So really, at the same time that we implemented this alternative payment, the state went through a major transformation of the Medicaid system by the creation of these coordinated care organizations. So this was done through an 1115 waiver that allowed the state the flexibility to really focus on the triple aim. Now we call it the quadruple aim, to adding equity in there, but to improve health outcomes, patient experience, and lower total cost of care. So they made an agreement with the federal government to have the flexibility to move forward with this, with the CCOs, and then the feds provided funding to allow that to happen. So the CCOs, they and there are 13 of them across the state. So anywhere that you live within Oregon, there's going to be a CCO, at least one. In some areas, there may be more than one, and this is for Medicaid primarily, that will coordinate your physical benefits, dental, behavioral health, and things like non-emergency medical transportation. So they take the risk. The state has moved the risk for this population to these private entities called CCOs, to really achieve the triple aim. And so as a health center, we contract with those CCOs that are in our area. for the delivery of services. And along with this move towards or built into the coordinated care organization was a focus on quality and hitting quality and targets. So for clinical metrics, things like cancer screening, diabetes control, immunizations, well woman exams, things like that. There are targets that the state arrives at as a whole, and all of the CCOs adopt those metrics. And then if they achieve those, then there is a payment, a pay for performance that is received by the CCO and then shared with the providers. And so this is a big component to the value-based pay. So that was when it started back in 2013. But then there's now we're into the second phase of this called CCO 2.0. And the governor said, okay, we've got a great start, on transforming the model of care in the state, but we need to do more on behavioral health integration. We still have silos. So there's a real focus on the integration of behavioral health and then paying for value. This changing the methodologies, to be more population health focused. And then also a greater focus on social determinants of health and health equity, and then managing the cost. This is making the overall cost of the Medicaid program sustainable. So under the value-based pay focus of the CCOs, it's really trying to move us from fee-for-service that you see here on the left, moving further and further over to the right to a population-based payment. So currently for Virginia Garcia, we're really kind of in that category 3 to 4 area where we're receiving partial capitation, and we are receiving pay for performance for hitting quality metrics, and we're now beginning to engage in contracts for shared savings. So this is that element here in category 3, which is important, but it's for not for taking risk at this point. So there's no downside risk for the health center right now. So if there are high costs of claims because of our patients ending up in the hospital or things, we're not penalized at this point for those costs. We only share in the upside. I'll get more into that in a moment, but as we move more to the right for population-based payments, it also moves the provider along a continuum of accepting more risk for the population, more financial risk. So we'll talk about that in a moment. So when we think about the value-based care and shared savings, we have to understand what the total cost of care is. So we're used to looking at what are the costs for primary care? What are the costs within our health center, within the walls of our health center? But a broader look, a broader population view includes, all of the costs for when the patient is accessing care outside of the health center, also in the hospital, at the emergency department, for specialist visits, for pharmacy, for other kinds of services outside of primary care, which make up most of the costs. Primary care usually only amounts to 10-12% of the total cost of care. But this is where health centers are working within the primary care setting. And yet when we look at total cost, it includes all of those other elements. And so we are now beginning to receive data from our CCOs that can tell us what is the total cost of care for the members that we have. And then we can look at how that changes. Are patients ending up in the hospital more or less, or what are the trends there? And so the data for managing value-based pay contracts is super important. That is critical. It's really hard to move forward with value-based pay contracts without a robust data system. So all of that is important so that we can understand if we are hitting those targets from a medical expense ratio. So each of the coordinated care organizations, they receive a premium from the state Medicaid agency in Oregon. It may be different in your state, but they receive the premium to manage the benefits for their population. So they have to cover their administrative expenses. And so they have what's called the medical expense ratio target. So in this example, they may have a target of 85% or 92%. So if 92% of all of their premium is used to pay for medical expense, that allows them to still cover their administrative costs. And if the health center is managing their population so that the actual medical expense ratio maybe is less than 92%, maybe 85%, then there's a savings. There's like a 7% savings, which then can be shared with the health center. And so in contracts that we're setting up, and we currently have one contract like this where the health center can receive 25% of the savings. And this is, again, not taking any downside risk. Okay, so if the medical expenses went to 150%, we wouldn't have to pay for that that surge of costs. But if we hit a target of keeping the expenses lower, we share in those savings. So this is something which is now becoming more common within how a health centers contract for value-based pay. But as I mentioned, the data is critical to being able to perform well in this system. You need data to understand the cost and utilization, of your members, of actually just even knowing who your members are. So on a monthly basis, we receive lists from both the CCOs and from the state that tell us, these are the members who you are being paid for. You're being paid for these members. You need to manage those members. You need to keep them engaged. You need to help them hit their quality metrics. You need to, try to manage them so that, their costs are not above the targets. So you need the data from the health plans, but you need data from your electronic health records and all of that to be able to provide the information you need to manage. And now more and more, it's in terms of collecting social determinants of health information. Is the member also homeless? Are they, Do they have food insecurity? Is there a history of trauma? Are there other stressors? All of those things can also impact the not only the health but the costs of the patients, and so that those are important things for us to understand, and so important to begin to collect and include in our data systems. And then our data systems also help us in our innovations. So over the last year, we of course have moved a lot to telehealth because of the pandemic, and this is something which has been supported by alternative payment methodology, because if the patient, if we're able to do that visit over the phone or by video visit, that there's no decrease in reimbursement for us, because we're paid to manage a population, not for a visit, not for a procedure. And then also the data systems allow us to evaluate the effectiveness of the value-based pay arrangements. And the state has done independent evaluations of the APM and have found improvement of care, of quality, and decreased costs. And this is an independent analysis from the health centers themselves. So we weren't sure how the research was going to come out on that, but we were delighted to see that it really encourages the move in this model. The other thing that a value-based pay approach looks at is not treating all of our patients the same, just understanding the complexity of our patients and looking at different conditions that they have, and then aligning the services to meet those needs that the patients have. So, building team structures that may be more focused on more complex patients. So we have a team which is really working with a comprehensive array of conditions that our patients have, who are higher on that cost and utilization side of things, and so that they need more support. They need more behavioral health, more clinical pharmacy, more outreach. But so we need to understand our patients, and then we also need to understand, again, what the social determinants of health characteristics are, so we can make sure that those needs are met as well, and also start to incorporate those into the risk assessment of our patients. Currently, health plans don't look at social determinants of health in establishing rates. And we're trying to develop and collect the data to show that it makes a difference if the person is high on a number of on trauma or in social determinants, that it's going to be harder to take care of them. That should be recognized in the rate of reimbursement. And so this is something that we're working on, hasn't yet been implemented in our rates, but it is something actually that the state in Oregon is very interested in, and so we're working with our CCOs and with our health center controlled network to try and collect that data. So how we do that? We do it through a variety of ways, but one way is through pictures. When our patients come in, and they can circle, are they having issues with housing? Are they having issues with food or stress? And so as part of our OCHA network, we've collected over 32,000 screens in Oregon over the last year. And there's a kind of a breakdown of the different issues that come up, like physical activity, stress, financial strain, food insecurity, housing, all of those things that we can then integrate into our care plans and to the electronic health records. Income, we see is a driver of the stress and issues that our patients have. So in our area, the median income, and around $3,000 for a single person a year, but when you look at what it takes to meet the needs of the family, that just gets you to basically covering, maybe if you're lucky, your rent and your childcare, and then when you look at adding on top of that food and healthcare and all the other expenses, these are things that many families just don't have that income. So that creates incredible stress on the families, and that impact in turn impacts their health. So as a health center, we're trying to understand, what those stressors are. Not that we can resolve all of those things, but at least in our center alone, but we can connect them with partners, with housing partners, with community action, with others to address their needs. So I just want to say a word on how APM has helped stabilize us, during this last year, the pandemic. For a year now, over a year, we have really pivoted to being almost more public health than we are, the normal primary care services. So we have really focused a lot on testing out in the community as well as in the clinic. And we are now pivoting to vaccines. We have a goal of vaccinating 30,000 people in the next 12 weeks. We're about 10,000 patients vaccinated on our way to that goal. And that's, we've been given flexibility by the state to vaccinate any one of our patients, regardless of age. So that's allowed us to really focus on some of the essential workers, those in the nurseries and the migrant camps are now we're starting to have people arrive, so we're developing plans there to bring our mobile clinic out and vaccinate primarily with the Johnson & Johnson vaccine, so we can do a one dose. And so that is all going very well. But the APM has really been a stabilizing force for us during this whole time. Again, not dependent on just those fee-for-service visits, procedures, encounters coming into the clinic, but really paid to care for that population. And what we see the high priority is to get people vaccinated, to get people tested. And so we're able to do that pivot and to pivot to telehealth without a loss of income. So our revenue has actually gone up during, in most lines of service, except for dental, because dental was really based on the old fee-for-service and encounter base. And then we had to pretty much shut our dental services down in the early days of the pandemic. because of the risk. And now we've been able to open that up and provide dental services. And so that's really starting to rebound. But overall, our revenue has improved over this last year, especially with the inclusion of the federal and state grants that are coming our way because of the CARES Act and also now because of the American Rescue Plan. So I think that I will stop there and see if there are any questions or comments. I'd really be interested in hearing on, if you have begun to move along this path of value-based pay in your own state, in your own health center. What are the challenges that you're running into, or what are the opportunities that you see? So maybe we can have some dialogue around that. So Maribel, I don't know if there have been any questions or anything in the chat.
Yes. Well, first of all, there's been a lot of shout outs on the great work that y'all are doing, Gail. And then there was, and some great presentation comments, but there was a question from our colega M. Rivera asking if y'all are only based in Oregon.
Yeah, so we're only based in Oregon, in 2 counties in Oregon, Washington and Yamhill counties. And that really has been by design and by a lot of discipline by the board of directors that has really said we need to focus, in our local community, and until we can, satisfy all the needs that we have in our local, we're going to resist the temptation of spreading ourselves too thin.
Great. Colegas, at this point, we invite you to turn on your cameras and consider asking questions. I saw someone unmute themselves. We have colegas from Finger Lakes, from Tri-County, from Valley View Health Center. So I don't know if folks want to speak to some of the questions that Gil posed at the end, or colegas, any questions, comments? Yep, there's a question that just came into the comment box. Gil, can you share more about how CHWs are paid for through the value-based pay and the CCOs, alternative payment models?
Right. So the way that in Oregon now, and Virginia Garcia was among the first 3 to adopt the alternative payment methodology in Oregon. So the way that we're paid by the CCOs is through capitation. So we get a per member per month rate, for the number of members assigned to us by the CCO. So for example, Virginia Garcia has about 33,000 members assigned to us by the CCOs. So for each one of those members, we receive a per member per month payment from the CCOs. But then on top of that, we're also receiving a per member per month payment from the state that reflects the wraparound, what normally would be billed, for your PPS wraparound rate. So we're receiving really 2 streams of payment for the population that we're serving. That's the main basic reimbursement that we receive, but then we also have opportunities if we hit quality metrics to receive bonuses, you might say, for hitting, controlling our diabetics and for doing the cancer screenings and all of those. And those have become more and more significant. Over the years, we receive about $4 million a year now in those kinds of quality incentive payments. So it is about half of what we received from our federal grant. And this is through these sorts of hitting the quality metrics. So that incentivizes us to invest even more in the teams and in our systems to be able to deliver high quality care.
Gracias, Gil. And could you share some advice on how the migrant voucher programs could start adjusting contracts from FFS to a value-based payment methodology?
Yeah, so I highly encourage you to work through your primary care associations, and develop a vision, and a roadmap for how you want to engage with your state partners, to move this forward. The PPS rules within, the CMS allow for these alternative payment methodologies. And the good thing is that health centers are protected because the alternative payment can't be lower or return less than what you're currently receiving. So it's almost a no risk, proposition for the health centers. But it does require you to get the buy-in of your state Medicaid agency to move that forward. We started with the model of care. So engaging your state leaders on why it is better from a quality standpoint, from the triple aim, from equity, to adopt a value-based pay approach. And more they're beginning to recognize that, but they may not know how to move forward with that, and they're or that the PPS rules even allow for alternative payment. So in some senses, you have to educate your state partners, on what is possible. And there are, in Oregon, we have over half of the health centers now, of the 34 health centers in the state have moved to APM. So there's still some that are on that fee for service. Most of the large health centers have already moved to an APM. And so, and like I said, we have been on this for 9 years now. So there's some good amount of experience, and, we're all happy to share that, with people from other states. And there are also, the state association and others who can help support, states move in this direction.
Awesome. Muchísimas gracias, Gil. I know we just have a couple more minutes left. We have another question around, I think we just had another question come in. Are you all thinking about expanding anytime soon? Gil, we really want to see more Virginia Garcias around here.
We have been expanding. We have 21 sites currently that both include our school-based health centers as well as our working in community mental health organizations. So we do a reverse integration where we bring primary care into the community mental health groups. We're doing most of our expansion that we're looking at right now is out in the community, in using our mobile services and looking at how can we be, at apartment complexes, for example, migrant housing, at the Head Starts, or, in this last year in the pandemic has shown us the effectiveness of working with community-based organizations to really reach, populations that have a harder time accessing. So we will most likely be doing more of those kinds of activities, but then also looking at how to build even more robust training programs, to get more, not just providers, but, nurses and community health workers and psychologists and others trained up in our model of care. So there's going to be a lot of focus there. And then on our school-based health centers, which we see as really important component of the model. So sorry, not going to other states at this point, unless, of course, I don't have the final say on that. That's our board of directors, and they could decide, tomorrow that they want to go, and start one in Hawaii. And I would be happy to actually move there and help out on that one. But for right now, we're going to be focused on the over 600,000 people within our service area, that we want to provide high quality care to.
We have 1 minute. Angeles, do you want to unmute yourself? I tried doing it, but go for it. You had raised your hand.
No, I did not. I was just saying, why not he moves to Colorado instead of Hawaii?
Actually, my daughter's in Colorado going through nursing school there right now, and she loves it and has been working at a health center in Denver that works with the homeless, and it's been very enthusiastic. But they're wonderful health centers in Colorado, and so I don't think we can match what they're doing already in their local community.
Well, when you're hiring in Colorado, when Virginia Garcia is hiring in Colorado, you're going to have to call Angeles. And when you're hiring in Hawaii, call me. Gracias.
Good idea.
Will do. I'll make a note.
Gracias, colegas. Feliz last session of the day. Muchísimas gracias, Gil. And thank you. Extend the thank you to your team. You are doing amazing work. We can't wait to hopefully see you all in persona next year when we're hopefully in Oregon.
Absolutely. Looking forward to it. Okay, take care. Have a wonderful rest of the conference or the start of a weekend, if that's where you're at. Okay.